I'm Dave Johnson. I'm an advanced care paramedic and a community paramedic from Hennepin County Medical Center in Minneapolis. I come from the land that was built by Scotch tape, pacemakers, and Spam. A couple quick reference notes for everybody. Any reference to Hennepin EMS, that's the paramedic service that's operated by Hennepin County Medical Center in Minneapolis. Our dynamic deployment model places between 7 and 21 dual advanced care paramedic units in Minneapolis and 13 other suburbs. I'm trying to figure out the scroll here. Hold on a second here. Next, some of the metrics you may see in some of the stuff that's been published differs a little bit. I think I'm looking at different timelines than some of my chief staff are when I ran my data. So that's where you may see some discrepancies between our two data sets. Yeah, so let's get down to some brass tacks here. So my overall goal here is to show you how our program has taken out of control paramedic service growth volume, as shown in the upper left of the slide, and utilizes dual purpose staff to intercept requests for paramedic service, as well as improve access to primary care and internal medicine. Nope. If you do hear me refer, just out of habit, to 1010 Curry or Harbor Light, essentially what I'm referring to is the Salvation Army's Harbor Light Center. It's located in downtown Minneapolis at 1010 Curry Avenue North. It has a couple other nicknames as well, but we won't get into it. In 2014, they housed an average of 329 men and 150 women every night. In addition to emergency and overnight shelter, they have transitional housing programs, veterans housing, medical respite, and a residential chemical dependency treatment program. 80% of their residents stay in the free or emergency portion of the shelter and average about a 2-month stay during the course of that. In Minneapolis, there's about a dozen homeless shelters. Harbor Light accounts for about half of all 911 or paramedic service requests that occur at such locations. So over the course of 6 years, steady increases in public safety, Minneapolis Police, Minneapolis Fire, and then Hennepin EMS. Response volumes to the Salvation Army's Harbor Light Center have increased by nearly 300%, especially when we look at mid-2014, and have rapidly outpaced overall paramedic service growth volumes and projections. In 2014, Minneapolis Fire Department's leadership approached the Salvation Army to see if there are ways that this issue could be addressed. Minneapolis Fire was concerned that they were responding to the shelter twice a day. We were going there 4 times a day, but we'll leave it at that. As well as they realized that there's a huge disruption to the residents that are experiencing homelessness at the shelter, both as far as shelter dynamics, as well as the increased cost upon the society. As you can see, there's also a huge rise in Minneapolis police response volume during the course of 2014. The staff of the Salvation Army account that to a drug dealer that was very active in the area, has since been dealt with, and the response volumes have begun to stabilize to a certain extent. So to a certain extent, there's precedence for what we were looking at doing. During the course of developing our community paramedic program, we built a significant number of relationships outside of our organization. One of the ongoing favorite clinical education sites for our staff have been spending time with the homeless street outreach staff. And their manager shared a unique experience, or a unique program that's going on at Cass's shelter down in Phoenix, Arizona, where they put primary care paramedics into the shelter around the clock. The data is not peer reviewed, but they report about 30% reductions in 911 utilization. Thinking this little nugget, it got our team thinking. If they could do this with primary care paramedics, what could we do with our advanced care paramedics who are cross-trained as community paramedics? So, next, entering the stage is Hennepin Health, and as Dr. O'Meara was wondering about how we deal with healthcare, our screwed up healthcare system in the US, lots of alcohol and Quaaludes. That's how we deal with it. Hennepin Health is an accountable care organization, very similar to what the Oregon folks are experiencing, and also a prepaid medical assistance plan. It's available to Hennepin County residents only, and this also has specific contractor providers that people are allowed to receive their care through. In 2013, when I was getting our community paramedic pilot program running, Ross Owens, the director of Hennepin Health, approached me and said, we have ways of making good things happen if you ever run into problems. What he was referring to was the reinvestment initiative that they have. Their unused monies that they don't use during the course of the previous year are reinvested into the system, trying to challenge the status quo. So in late 2014, following some internal conversations with Hennepin Health movers and shakers, we were solicited to apply for their competitive grant process. Ultimately, we applied for 1.2 full-time equivalents, 2 point-of-care analyzers, portable radios, some allowances for technology, administrative fees, and also a squad car. A couple months later in December, we were informed that we did receive an award, and the only thing that that got declined was the purchase of a squad car, which coincided really well with our chief of EMS and our chief of operations losing their take-home vehicles, so we took their cars. That worked out really well for us. But we did encumber our budget of about $154,000 in the first weeks of January 2015 and got right to work. Apparently Hennepin Health is used to most of their awardees taking about 6 months to get their programs going. But come the 1st of March 2015, we had community paramedics at Harbor Light. The other thing that's worth noting, although Hennepin Health is an insurance plan, they were fully aware that we were not going to be restricting this just to their recipients. They knew that there's a large portion of people at the shelter that are not insured by them. Ultimately, we're seeing about 10% Hennepin Health recipients. About half of them are Medicare recipients, and then through some of the other PMAPs that we have to deal with. And then also we have been renewed for a second year, so there are opportunities to extend it beyond just 1 year of award. So the next people that are entering the stage. In the United States, Healthcare for the Homeless is a federal program, and the administrator of the program in Hennepin County is the Human Services and Public Health Department. Healthcare for the Homeless offers 9 multidisciplinary clinic sites staffed with physicians, nurse practitioners, pharmacists, public health nurses, social workers, medical assistants, mental health case managers, office specialists, and so forth. This team offers a wide array of services to patients who use the clinic, but they're really just a health clinic. They're not long-term primary care, internal medicine. They want you to go somewhere else for that. They're just very much ad hoc. So we've sifted down all the other shelter sites, and we looked just at what Harbor Light has at their site. And you can really appreciate the robust 44 hours of footprint that they do have at this shelter, even going into 7 o'clock in the evening twice a week as well. When we looked at our paramedic response data, we found that the best use of our 40 hours that we had been awarded was during a cluster between Sunday and Wednesday from 4 p.m. until about 2 o'clock in the morning. So that's what we deployed at for the first month. But we quickly realized some issues with that coverage plan. First, starting in 2014, which we didn't realize, that was the first year that Harbor Light had the clinic shelter open in the evening on Tuesdays. It's not the biggest space in the world. You had 6 clinic staff and 1 or 2 community paramedics, and it's a little bit crowded. Also coinciding with the start of our grant was the shelter instituting a 10 p.m. curfew at the shelter, unless you have a work pass, in which case you can get in after 10 o'clock. But with that, we really found that we weren't seeing anybody after about 22:30. So this is our current model. It's a really happy place for us. We adjusted after the first month, starting in April of 2015, and now we're there from Friday through Monday from 2 o'clock until midnight. So as we planned a couple of the other specifics of our program, we had a couple key points that needed attention. First, at the outset, we felt that a strong emphasis on relationships was imperative. So we identified 2 community paramedics who would be tasked with being the primary staff assigned to the program. They would be tasked with integrating themselves with the housing floor advocates, shelter security staff, healthcare for the homeless, but most importantly, the residents of the shelter. We want the shelter to know who their community paramedics were. Too far. Our staff also would need enhanced standing orders, as previously our community paramedics had intentionally worked in a very gray area as we developed the program without a whole lot of rules or regulations to allow it to fully spread its wings and to figure out what it wanted to be when it grew up. The approach that we chose was to build addendums to a number of our paramedic service care guidelines to allow them to utilize their expanded role, still under a structure that they already are familiar with. And finally, probably the most important step was to figure out some way to abandon emergency physicians as our source of medical control. We are working after traditional physician office hours, and if our goal is to keep people out of the hospitals, just as primary care physicians are typically not great emergency physicians are typically not great primary care physicians. We'll talk a little bit more why that's a good approach in a second here. Other things that were part of our grant, we got the 2 portable the point of care analyzers. We went with the iStat, and we're using the chemistry 8 panel as well as the international normalized ratio. We felt that that was important because if a resident presents to the community paramedic feeling like rubbish with a blood pressure of 180 over 120, being able to run a chemistry panel, identify their potassium's good, their creatinine at baseline, and oftentimes we can just call our on-call physician, and they might be willing to write us a script for a beta blocker or hydrochlorothiazide or something like that to get us through the next couple days until they're able to get in with their primary care provider. And then they can also shoot that script right to the 24-hour drugstore that's about 1 block from the shelter. So when we went to the shelter, we were trying to figure out, we kind of had a good idea of what we were going to end up encountering over at the shelter. We found that we knew that we were going to go over and see a lot of diabetes. We knew we were going to see a lot of chemical dependency, a lot of mental illness. But I think all of our staff remarked that they were really shocked by how much hypertension they were seeing, as well as the dermatology that we'd have to learn, which is quite the steep learning curve for us, because it's not really part of traditional paramedic education. The nomadic lifestyle of people experiencing homelessness, they deal with a lot more issues like trench foot or tinea pedis, as well as just a wide variety of every type of dermatitis you can think of. So we have a car. We stole it from our managers, but we have a car. So our paramedics have been given permission to exercise good discretion. There's an appreciable number of the requests for paramedic service that can be solved with much more appropriate solutions. Ride to the pharmacy so the patient can pick up their prescription for their ACE inhibitor. If the police drop off a cognitively declined person because they had no idea where else to put this person, they do have a home. We just need to dig through the chart maybe a little bit and figure out where it is. Or maybe a resident who fell and needs a couple sutures. Do they really need 2 advanced care paramedics and an ambulance to drive them across downtown Minneapolis? Not really. We can probably just put them in the car and give them a ride over to urgent care, which works out really well. So let's look at some data, because that's been like the magic D word for this entire today, I've noticed. With a relatively small n, our data was difficult to appreciate when you looked at the trends from a monthly standpoint. So the approach that we've taken is to look at it as monthly averages per quarter. It's a little bit awkward to look at, but it makes the visual look at the data less abrupt. We also are going to look largely at response data for our paramedic service, as we feel that our deployment at the homeless shelter telegraphs to our traditional operation, or telegraphs to our traditional operations. Also, our quarters are aligned with our deployment cycle. So we went into the shelter on March 1st, so March to May, June to August, September to November, and December to February. So, using the equivalent quarter from 2014 as our benchmark, our goal in our grant application was to achieve 10% reductions in requests for paramedic service. Some quarters we were much more successful than others, but overall, during the course of our first year, we saw an average of 16% reduction in requests for paramedic service. Our Q1 2016 is not great because we actually had a 2-week funding gap, so we actually weren't at the shelter for the first half of March of this year. So that's what I think accounts for that. Next, the magic question we have not been able to figure out: how do we document the fact that we help people access primary care? Many of you are EMS chiefs and whatnot. You understand how you justify a successful paramedic service. You have discrete metrics. You can measure the percentage of successful endotracheal intubations, response times, hospital times, and so forth. But this is something we've never had to try and figure out how to document before. And we're still trying to get it figured out. It lives in our electronic health record. We're still trying to figure out how to penetrate that to a certain extent and get and get data from it. We're only 3 people in an organization of 6,000 people. So trying to get our Epic analyst time is like pulling teeth without a whole lot of manual data review. Also, we still feel this is important, and we have a lot of anecdotal evidence supporting this, but Harbor Light is a really ripe location to help people engage with primary care. The lion's share of people at the shelter do have a primary care provider, but Minneapolis also welcomes a large number of immigrants, both domestic and international, partly due to a reputedly good social support system, low unemployment. We end up seeing a lot of people coming up from Chicago, Indianapolis, the Gulf Coast region. I suspect they come for our enjoyable average January high temperature of -6. I know you Canada people are all, ooh. But again, anecdotally, I know we're making great strides in getting people engaged with a primary care provider, and even more so getting them established with the correct primary care provider, somebody who's able to understand the complex issues surrounding the experience of homelessness. I worked at the shelter on Friday and Monday of last weekend, and during the course of that weekend, my 2 shifts during the weekend, I saw 24 patients on Monday, and I think about 20 on Friday. And I got 4 of them arranged to establish with a primary care provider, and also 2 of them set up to arrange with a primary care behavioral health provider as well. Now, that's all fine and dandy, but are they actually going to show up for those appointments to establish care? Did they develop a meaningful relationship with that provider? It's a lot of manual chart review and general conjecture, and honestly, we haven't had the resources to do it yet. So the next metric that we looked at was related to improving the efficiency of our ambulance use at Harbor Light. Harbor Light's traditionally maintained a higher percentage of calls for service that result in hospital transportation, but we have had up and down months. But generally, we feel that the trend continues in upward direction towards improved efficiency of our paramedic service. Some of the factors that I think contribute to this may be better triage by on-site medical staff, such as healthcare for the homeless, or by our community paramedic staff, or else potentially due to a sicker population, and being able to do the manual chart review to figure out, did these result in a hospital admission? That's the long-term goal. Don't have it done yet. I know in my abstract I made big promises, and I'm totally not delivering on them. So with a weekday population of about 500,000 people in downtown Minneapolis, fewer paramedic ambulances busting hump across downtown is probably a good thing for everyone. Traditionally, Harbor Light Center has been below department averages for non-emergent response, but we quickly flipped the script once we went over to the shelter, and now Harbor Light runs about 10% better than our overall paramedic service response requests. And then really the first people to get this conversation going was the Minneapolis Fire Department. Minneapolis Fire Department is one of our response partners. It's staffed by firefighter, primary care paramedics. Well, it isn't perfect because I didn't call the request for fire suppression service. Minneapolis Fire came on about 40% of paramedic service calls in 2014, and in 2015 they only came on 31% of requests for service. Now we look at the graph on the right side of the screen, and this was created without cherry picking any data. All Minneapolis Fire responses were taken into account, fire and medical. They're not separated because ultimately I think that there's some remote interdependence between the two as far as calls for fire service as well as, and also never have our friends at Engine 16 loved us more. They are very happy that we are over there. So that's about what I have for all of you. I appreciate your time and your attention, and that's it.